So today it's our pleasure to have one of our new local faculty in the Atlanta area, Sana Van Rooij from Emory University. She is an assistant professor in the Department of Psychiatry. She did her PhD in clinical neuroscience in the Netherlands and then moved to Atlanta to do a postdoc and recently became independent and has her own lab there in the Department of Psychiatry. She's a winner of the NARSIDE Brain and Behavior Young Investigator Award, and she also recently just got a K Award, which is a transition grant for new young faculty. She's going to tell us about the work that's going on in her lab and tell us about PTSD and neuromodulation. So, Sana, thank you.
Thank you so much for the invitation to speak here today, and thank you for the introduction. I will be talking to you about neuromodulation targets for PTSD using neuroimaging, and I will start by explaining PTSD and its neurocorrelates, and we'll present data of the Grady Trauma Project. Then we'll talk about neural mechanisms of PTSD treatment and end with novel studies on neuromodulation for PTSD. So this is probably going to be a more clinical talk than most of these talks in this series. So start with talking a little bit about what post-traumatic stress disorder is. It's a debilitating psychiatric disorder that one can develop after experiencing a criterion A traumatic event. And a criterion A traumatic event is exposure to actual or threatened death, serious injury, or sexual violence. And exposure means that someone can experience it themselves, can witness it, or learn about a family member or close friend having experienced it. About 70% of individuals are exposed to a traumatic event in their life. However, about 6 to 8% of the general population develop PTSD. And PTSD has like 4 different symptoms of clusters of symptoms. So the first cluster, cluster B, is intrusive memories of the traumatic event. And these include like flashbacks to the traumatic event is probably one of the most well-known symptoms of PTSD, nightmares, intrusive thoughts about the trauma. And then a second set of symptoms are related to avoidance. So that means avoiding reminders of the trauma. This can be if your perpetrator was wearing a blue jacket, you may try to not go on the street to like not see anyone wearing a blue jacket, so they can kind of become extreme. People also try to avoid thinking about the trauma, and one way people do that, and this is not always the case, but it's definitely comorbid, is by using substances. Then we see negative changes in mood and thinking. People have like a more negative outlook. And finally, PTSD consists of changes in physical and emotional reactions. So people with PTSD tend to be more hypervigilant. They're like scanning the room for, or like the area they're in for potential danger. They have problems with sleep and attention, and they have like a stronger startle response, so they are more jumpier. Not one PTSD patient is the same as another, because you don't need to have like all of these symptoms, but you have to have a mix of these 4 symptoms in order to meet for PTSD. I want to talk to you about the Grady Trauma Project. This is a group of investigators studying PTSD in a civilian population since about 2005. Up until then, most people know of PTSD as an issue in veterans or victims of rape, but this study really focused on a civilian population. It's currently being led by 3 co-directors, Dr. Mikopoulos, Stevens, and Powers-Lott. And in this study, patients are recruited from Grady Memorial Hospital. This is a publicly funded hospital in downtown Atlanta. This hospital serves primarily inner city low-income minority population. And in the Grady Trauma Project, we have collected data of over 12,000 patients by now. And in our population, the majority is Black or African American, has no college education, and about 55% have a monthly income for the whole household of less than $1,000. So how we recruit patients, and this is pre-COVID times. We have an army of volunteers. They go into the waiting rooms of this hospital. And because it's a publicly funded hospital, people often have to wait a long time before they can be seen for their appointments. So we would approach an individual waiting for their appointment just at random. So this is not in a psychiatric clinic. This is just in a primary care or OBGYN clinics. We would ask them if they're interested in participating in a research study on stress and the effect of stress and the effect that the stress has on them. We would basically conduct a little interview there with them, asking about PTSD symptoms, traumatic events, and how did it impact their life. So that way we have collected data, again, of over 12,000 people. And what we learned from that was that people have very high levels of trauma. So 80% of individuals has more than 2 types of trauma. So that means that they can have like 3 car accidents, and then 4 assaults and another life-threatening situation that they've been exposed to. So the median was 4 different types of trauma, and individual traumas were 28 traumas. And remember, a trauma is something that was either life-threatening or could lead to serious injury or was a sexual assault. So 28 traumas is like a very high number of traumas. And so the rates of PTSD are also very high in this population. The typical US population has, again, 6 to 8% of PTSD. In this population, we see around 46% of PTSD, and this even exceeds levels in a veteran population at around 31%. So in and of itself, this has been like, I think, a major contribution from this project, just to indicate that PTSD is related to trauma is really a big problem in this population. And aside from PTSD, this is also results in like higher levels of depression, and also like issues like diabetes are related to higher levels of stress. So one case example that I want to share with you. So this is one of the people that we have encountered actually in these waiting rooms is this 56-year-old African-American female. With type 2 diabetes. It's a grandmother with full custody of her 8-year-old boy. She has an MPSS, so it's like the old measure that we used for PTSD symptom assessment of 21, meaning she has PTSD symptoms, but it's kind of moderate. She has a BDI, back depression inventory of 10, so some depressive symptoms. And this is her little short trauma history. At 8, she was confronted with her uncle killing his wife and himself. Between 13 and 18, she witnessed multiple incidents of domestic violence between her mother and stepfather. Between 13 and 18, she was physically punished by her mother severely more than 20 times, and she was also verbally abused by her mother and stepfather over 20 times. At 16, she was sexually assaulted by a known adult, and again at 19, she was sexually assaulted, and she described that as her worst trauma. At 19, she found her brother shot and killed. She was very emotional throughout the whole interview, but adamant about continuing. She has current custody of an 8-year-old boy who's having behavioral issues in school. Patients reported alcohol abuse at 19 after the passing of her brother, but she no longer drinks alcohol. We offered resources for Chris Kids, which is now Chris 180. And then I highlighted in green things that we actually like to see, but do not always see in the patients we encounter. She has a high CD risk score. This is a measure for resilience, and basically resilience is how you cope with trauma in the face of adversity. So if you're able to, how well you're able to deal with traumatic events. So that was pretty high for her, so that's a good thing. She attends church regularly and is currently in therapy. She's taking trazodone, Wellbutrin, and Zoloft, and has been diagnosed with PTSD. Overall, this was an interesting interview our research intern summarized. So this is just one case example. There are individuals with lower levels of trauma, but there's also similar or higher levels of traumas that we encounter. So we again collected this data as well as a DNA sample in 12,000 individuals, have done diagnostic assessments, so more in-depth interviews to assess for PTSD symptoms and DSM disorders in about 1,000 individuals at least. Then we've done fear conditioning, psychophysiology study in about 800 individuals, and fMRI study in over 200 individuals. So that's sort of where we are. I like to focus mostly on the neurobiology, and specifically want to introduce the mechanism that we've been very interested in PTSD, and it's the mechanism of fear inhibition. So I always like to use this example as a way of describing what this is and how this is related to symptoms of PTSD. So fear learning is crucial for survival. If you're in a, this is an image of a war zone. If you're in a war zone and you hear like a loud explosion during your military training, you've learned that this indicates danger, and this explosion results in a fear response. Maybe something happened to one of your buddies there. So you learn that this sound that like happened with the explosion is fear, and that's a good thing, because that means like it activates your fight or flight system, so you are more alert, you have more energy to like respond to the situation. And so the next time you hear this sound, you again have this like fear response, or this fight or flight response. And again, in the war zone, that will help you to survive. However, when you are back in a safe environment, you have to regulate emotions and behavior accordingly. So I always put up this picture. As Bilal just mentioned, I'm from the Netherlands, and this kind of, to me, seems like a very safe place with like a little windmill and in the background. So when you hear a sound here, when you just came back from your military mission, the first time you may still be triggered to have this fear response. However, soon enough you realize that this sound most likely in this specific environment does not mean an explosion. So this fear will extinguish, as we call it, and so the sound no longer leads to a fear response. And this is what we call fear inhibition, which is the suppression of the learned fear in a safe environment. And that exactly is a key impairment in PTSD. PTSD patients are less able to use this contextual information to suppress their fear response. So to them, this sound, or any sound, and it's typically generalized, so any loud sound will result in a fear response. And I've once had a veteran tell me that every month there's like a test alarm in the Netherlands, that every month he would find himself under the table hiding because this sound like immediately triggered a response to him. So one way we measure this in the lab is this psychophysiological assessment, or a startle assessment. We have like a soundproof booth and place electrodes under the eye to measure the electromyography response, so basically the eye blink response. And if you get startled, you have like a stronger eye blink response. Then we present individuals with either noise alone or a danger signal, in this case a blue square, and that is coupled with a puff of air to the throat, which is aversive but not painful. And we also present safety signals, which indicate that the sound will not be followed by the air puff. So what we expect and see in individuals without PTSD is that during the acquisition, as we call it, they have like a higher response when one of the symbols is presented, either the square or the triangle, because they know something may happen. So they have like a stronger eye blink response, but soon enough they learn that it's really mostly the square that they have to be afraid of, and they like differentiate between the square and between the danger cue and the safety cue. PTSD patients, on the other hand, have first of all, a higher response overall. So they are more jumpier, as I mentioned, have like a higher startle response. But they also do not show this differentiation so much. And after the first session, when they've learned this fear, the fear acquisition, we move on to fear extinction, where they will hear this sound without the air blast. So basically the being back in a safe environment situation, except we didn't change the environment here. And here you see the difference between PTSD patients and controls is that the PTSD patients have a much larger response, even in extinction. So it takes them longer to extinguish this fear. And then moving on to the neurobiology, to brain regions that are involved in PTSD and are mostly related to this mechanism. So first is the amygdala. The amygdala is important for fear learning and the fear response. And in this model by Shalev et al., they distinguish the different nuclei and their specific roles. And overall, we see that the amygdala has greater activation in PTSD patients compared to controls. Then the second circuit that is involved in PTSD is a threat and salience detection circuit, which includes the amygdala, the insula, and the dorsal ACC. So the salience network, which is important for paying attention to salient stimuli. So it's good to pay attention to salient stimuli. However, if you always pay attention to something that could be remotely salient, your system is always on high alert, and that's typically what we see in PTSD. Then a circuit for context processing includes the hippocampus and the ventromedial prefrontal cortex. The hippocampus is important for the processing of this contextual information, and the VMPFC is important in downregulating this response. Both regions show typically lower activation in PTSD. And finally, the prefrontal cortex, including the ventromedial prefrontal cortex, is important for controlling emotions such as the fear response and control behavior when appropriate. So based on the contextual information, the PFC will downregulate the amygdala, the fear response. And what we see is that PTSD patients show a lower activation in the PFC. So showing you some data related to these brain regions from the Grady Trauma Project. First of all, the amygdala is, again, the fear center, so oftentimes referred to as the fear center in the brain. And when you show neutral faces compared to fearful faces, PTSD patients show increased activation in the right amygdala compared to controls. And this is work by my colleague, Dr. Jennifer Stevens. And here you see the right amygdala, and was particularly related to hyperarousal symptoms. Second, she showed that the amygdala VMPFC functional connectivity was decreased in PTSD patients. So assuming less control by the VMPFC over the amygdala, resulting in this heightened fear response. Then for another set of studies, we used a go-no-go task. So in go trials, participants see an X, and in no-go trials, participants see an X or an O, press 1 for an X, 2 for an O, and in no-go trials, you see a stop signal behind the X or behind the O. And so they're supposed to withhold their response. And response inhibition is defined as no-go trials larger than go trials. So Dr. Jovanovic, who was my postdoc mentor when I moved to Atlanta, showed that less VMPFC activation in PTSD compared to controls during this task, so suggesting less suppression, less control by the VMPFC. And this correlated with the fear-potentiated startle that I described earlier. And then finally, we have some findings related to the hippocampus. And again, in this population of chronically traumatized women using the same task, we showed that more hippocampal activation was related to lower PTSD symptoms and more resilience. And we replicated this finding in a study of recently traumatized civilians, also as part of the Grady Trauma Project, where individuals were brought to the emergency room and were scanned about a month later, and then PTSD symptoms were assessed at 3 and 6 months. And in this study, we also showed that more hippocampal activation was related to less PTSD symptoms at 3 and at 6 months in 2 independent samples. So again, suggesting that lower hippocampal activation is observed in PTSD. Then finally, one of the most replicated findings in PTSD is a lower hippocampal volume. And the largest study to date is where we also contributed some of our data to, is the Enigma consortium study on hippocampal volume and PTSD. So you see a lower hippocampal volume, both left and right, and marginally smaller amygdala volumes. There are much more neuroimaging studies and brain regions that are implicated in PTSD that have been studied, but this is kind of the short overview of the main findings. Because I would like to move on to the next part of my talk about neural mechanisms of PTSD treatment. So to start with a brief introduction of what PTSD treatment looks like. The recommended treatment for PTSD is trauma-focused therapy with or without medication. And trauma-focused therapy could consist of either prolonged exposure, cognitive behavioral therapy or CBT, eye movement desensitization and reprocessing, EMDR. These are like the most well-known forms of trauma-focused therapy. And while I'm not a clinician, so people have their preferred methods for a variation of reasons, the thing I will focus on for this talk is what they have in common. And trauma-focused therapy in general is centered around the idea that you activate your traumatic experience. You pay attention to relevant information, your safety signals. So when you have, like, you were thinking about this trauma, but now you try to reframe it and you're in this safe environment, and you integrate the information and learn new associations. So basically helping the extinction learning in a safe setting. This has been a very effective therapy for a lot of patients. However, still 30 to 50% of patients do not respond. And while we're on the one end going to want to try to understand neurobiologically how that works, it's also well noted, for example, the population of the Grady Trauma Project is less responsive due to low literacy and possible other issues. So because 30 to 50% of patients do not respond, we need first of all, a better understanding of non-response, and 2, novel treatment approaches. And that will be the focus of the rest of the talk. And And so, starting with a better understanding of treatment non-response, several pre- and post-treatment studies, neuroimaging studies, have identified possible markers for treatment non-response. So I want to show you some data from the work I did in the Netherlands as part of my PhD training, and this is the BETTER study. This was with Dutch war veterans and who were like scheduled to undergo trauma-focused therapy. So we recruited 50 PTSD patients and 25 controls. All of them received like an MRI scan, blood sample, and questionnaires prior to their treatment. Then they received around 6 months of treatment, and this was it was not a standardized treatment protocol. This was just like as the clinician saw fit. And we did another MRI scan, blood sample, and questionnaires at 6 months. And so based on the numbers, we expected that about half of them would respond and half of them would not. And then we would have the 25 controls. And it worked out roughly like that. So the first set of results from this study showed that the dorsal ACC, insula, and amygdala study were implicated in treatment response, and this is when we presented them negative versus neutral pictures. What we observed was that higher dorsal ACC, insula, and amygdala predicted non-response, but also that prior to treatment, the patients who would later respond to treatment did not differ from the controls, and only the individuals who did not respond were the ones who differentiated. And similarly, we observed what we observed for the hippocampus was that lower hippocampal volume was only observed in patients who did not respond to treatment, and combat controls and the remitted patients did not differ so much. So this, to me, kind of suggests that the neurobiology that puts you at risk of developing PTSD may also put you at risk from not benefiting from this exposure-based therapy. Finally, this is like unbiased whole brain analysis using a task focused on processing of contextual information, and we observed a region that we did not so much expect, the left inferior parietal lobe, to predict symptom reduction, and the left IPL is involved in working memory updating. So if you are better able to update your working memory when processing contextual information, this may help to integrate novel information and benefit from treatment, is what we hypothesized. There are several other pre and post neuroimaging studies on treatment. So the first series of studies was performed by Richard Bryant in Australia, who showed that both the amygdala and the dorsal ACC correlated with symptom outcome after treatment in the same way. Like more activation was a lower treatment response. This is work by Gregory Fonzo and Amit Atkins' lab, who also showed the effect for the left amygdala being predictive of the treatment outcome. Amit Atkins showed the ventral attention network within connectivity in this network was related to treatment outcome, but only in individuals who also had impaired memory. So if you had low ventral attention network connectivity and impaired memory, you were at risk for treatment non-response. And finally, one study I want to highlight is a study by Rubin et al., who also found the lower hippocampal volume and nicely replicated our finding, which is always nice. Summarizing these findings in this model, we observed that And this is generally speaking. So not all studies that we reviewed, not all studies point in the same direction, but if you like generally summarize it, it suggests that reduced activation of the prefrontal cortex is a predictor for treatment non-response. So reduced control over emotions and behavior is hampering treatment response. Lower activation of the hippocampus and the VMPFC, which could indicate reduced context processing and integration, which is predictive of treatment non-response. And then overall studies showed that heightened activation of the amygdala, dorsal ACC, and the insula were related to poor treatment outcomes. So this suggests a reduced ability to accurately assess threat versus safety and increased attention to negative stimuli. So if you really focus on like everything potentially threatening, you may not be able to integrate the safety signals. And there were no studies specifically on fear learning. So we summarized all this in this model of neural mechanisms of PTSD treatment, and this is currently under review. So overall, this model suggests that if you have like reduced activation in your emotion regulation, executive function, and contextual processing circuits, and greater activation in your threat and salience detection of your learning circuits, you are more likely to not respond to trauma-focused therapy. Again, with the caveat that there's a lot of evidence is just based on 1 or 2 studies, and it's not all pointing in the same direction, but this is the overall picture. And with that overall picture, we aim to put it together in this model and suggest targets for neuromodulation treatments, because if you can target the brain regions that are not functioning properly, you can maybe sort of prepare the brain for trauma-focused therapy, or maybe it can be a therapy in and of itself. So there's 2 possible directions that you can take with that. So looking at this overview, there are a couple of studies that are currently underway that do indeed target these regions. So one of them is TMS to the medial prefrontal cortex, or TMS to the dorsolateral prefrontal cortex, both with the idea of eventually reaching the amygdala. Then there's 2 DBS case studies. One DBS case study focused on the amygdala and showed promising result, and one DBS case study targeted the uncinate fasciculus and that connects the prefrontal regions with the limbic regions, and also showed great promise for that. Then there's, based on our review, there's a couple of other potential approaches that people could assess, which could be TMS or DBS to the dorsal anterior cingulate cortex, to the insula, same way, and TMS to the inferior parietal lobe could be to like increased working memory updating, could be a potentially interesting approach. Most studies were the most convincing evidence by far, though, was the amygdala. So 6 studies showed that gradient amygdala activation was related to poor treatment outcome. And to summarize some of this, I've presented already, but to again summarize, the role of the amygdala in PTSD is really quite convincing. So increased right amygdala activation has been observed in PTSD patients compared to controls, and Dr. Stevens also showed that in the same emergency department study that I showed earlier, that more amygdala activation, greater amygdala activation predicted the development of PTSD. And a totally different approach, work by Koenigs et al., showed that brain damage, including the amygdala, protected against the development of PTSD. So again, suggesting the role of the amygdala. Then, as I just presented, the amygdala was predictive of treatment non-response. And Greg Fonzo et al. Used TMS to the right dorsolateral prefrontal cortex during fMRI and showed that that way they could inhibit the amygdala, which improved treatment outcome. So taking this to the final part of this talk on novel studies on neuromodulation, and really going to work around the hypothesis that reducing amygdala function would improve PTSD treatment outcome. And one way that would be the most direct possibility to assess this if we could remove the amygdala, which sounds very crazy. It sounded very crazy to me until I met Dr. Willie, who's a neurosurgeon, and collaborated with Dr. Bajanki and Dr. Inman on their work in epilepsy patients. So epilepsy patients undergo ablation of their, for example, the amygdala as a treatment for their treatment refractory epilepsy. And the amygdala is oftentimes the focus of the epilepsy and therefore the target for this treatment. So Dr. Willie has encountered the first case of a 62-year-old white male with a 30-year history of combat-related PTSD and right medial temporal lobe epilepsy. And this patient underwent uncomplicated right laser amygdala ablation. And post-surgery, this patient not only was seizure-free for 12 months, throughout 12 months of follow-up, but he also showed amelioration of PTSD symptoms as reported by himself and his wife. He had like a reduction of hypervigilance, anger, irritability, showed an increased emotional range and improved mood, showed improved anxiety and depression symptoms, and was able to start and engage in trauma-focused therapy. So the next time a patient presented herself with, again, a history of PTSD, we collaborated to get as much information on her as possible. So this patient was a 42-year-old Black woman with a 19-year-old history of civilian-related PTSD and right medial temporal lobe epilepsy. She was refractory to psychotherapy and antidepressant medications. She again, just as the other patient, underwent the right laser amygdala ablation. She had pre- and post-surgery assessments. We did clinician-administered PTSD scale, the CAPS-5. We did an fMRI scan and fear-potentiated startle assessment. So her CAPS interview suggested that she had witnessed an aftermath of the death of a relative and fatal violence to family members. Pre-surgery, she had significant PTSD symptoms. And at 6 months, the symptoms decreased by 30%, and at 12 months, they decreased further to a 66% decrease, mostly in negative alteration of cognition and mood and hyperarousal symptoms. And she did not meet for PTSD anymore. And one very interesting thing that she mentioned to the clinician at 6 months is that she would still engage in certain behaviors. She would still look out the window she was still hypervigilant. She would still look out the window and check for danger. But then she didn't feel the anxiety anymore. So the amygdala was no longer sending this, inducing this fear response, but she still had this habitual behavior. And at 12 months, this had further declined to she did no longer report this behavior either. So we also collected neuroimaging on this patient. We showed the fearful faces task and indeed saw greater activation in the amygdala. We saw reduced activation in VMPFC and high and greater dorsal ACC activation, kind of a typical pattern for PTSD patients. And after her surgery, these markers normalized, so lower amygdala activation, her VMPFC activation reduced, and dorsal ACC also normalized. Fear-potentiated startle we assessed as well, and we see that she showed she basically did not discriminate between the fear and the safety cues. If anything, she showed a greater response to the safety cue. And at 6 months, we see a large reduction here, and she now is able to discriminate between the fear and safety cue. And emotional memory was also assessed and was not impacted. If anything, it improved somewhat. So then finally, a third case was a different case of 32-year-old white female with a previous partial right temporal lobectomy. So she has had surgery, but her right amygdala was spared, which is important because then 5 years post-surgery, she experienced a traumatic brain injury because of a car crash, and seizures recurred and PTSD developed. So because she had a right amygdala, we believe that she was still able to develop PTSD. She underwent right amygdala resection in open surgery, and post-surgery her seizures improved but still persisted, but she did not meet for PTSD anymore, and you see her drop in her symptoms here. This is at 6 months post-surgery. So the conclusion of this is that the study provides some insight into the causal role of amygdala in PTSD symptoms and biomarkers, and so far it looks like it's specifically the right amygdala. Interventions targeting the right amygdala could be therapeutic for PTSD, and future directions on the one hand include increasing the sample size of this ablation study to further assess what exactly the area of the ablation is and how that influences the findings. The patients also had like a part of their hippocampus removed. Then is it really the right or is it also the left, and what is it about the right, and what kind of patient characteristics are important? But another direction that I'm taking this research is to use TMS to target the amygdala indirectly. So for the last part of my talk, I'm switching to transcranial magnetic stimulation, which is an FDA-approved treatment for major depressive disorder. And the mechanism of action for TMS is based on Faraday's principle of electromagnetic induction. There's a rapid variation in electrical current here, and the coil can induce a magnetic field perpendicular to the coil for about 1 millisecond, and this rapid change induces an electrical current in the area under the coil, which activates neurons. Very briefly. And TMS as a treatment for PTSD has several advantages. First of all, it's non-invasive, and it's a very safe and easy method. And it also works around barriers of trauma-focused therapy that I mentioned before. For trauma-focused therapy, individuals have to receive homework, and you have to be cognitively able to do it, which especially with a low literacy that we observe in the Grady Trauma Project, not in all, but in some cases can be an advantage for a population like that. But it could also be used prior to trauma-focused therapy to like engage the system, engage like the neural system, and maybe prime it in order to be more responsive to the trauma-focused therapy. A disadvantage is that it's less focal, and so it's not possible to very precisely target the amygdala. There's a couple of case studies and small randomized controlled trials that have shown efficacy of TMS for PTSD. Some really good studies. However, most studies have focused on clinical outcomes, and mostly the mechanisms are largely unknown. Most studies either have a small number of sessions or a long treatment program. Most studies use the 1 Hz stimulation to the right DLP of C. However, there's no clear rationale for it. The left DLP of C has been used for depression, and the right DLP of C at a low rate, like 1 Hz, seems to work for PTSD, but no one knows why. And then most studies have used treatment-resistant patients that have undergone other types of treatment like trauma-focused therapy who have not responded. So you always work with a more resistant population. So in my KO1 study that we were hoping to enroll our first patient anytime in the next few weeks, this will be a randomized, double-blind, active versus sham clinical trial. We will recruit 60 mostly treatment-naive patients from the Grady Trauma Project, and we'll do the TMS at the TMS suite at the Emory Brain Health Center. We'll be able to Uber them over and make sure that they are able to come to our treatment sessions. The treatment sessions will be 2 weeks, 5 times a week, but then 2 sessions a day with a 10-minute break. So we will be able to do 20 sessions in only 2-week time frame. The treatments will be the 1 Hz to the right DLPFC, as again that has been shown to be effective in prior studies, and we'll use 120% of the motor threshold as a. Then this is the overview of the study. We'll start with the motor threshold testing, and then after that, a couple of days later, we will assess if people still meet for PTSD using a clinician-administered PTSD scale. Then we randomize them, or then we do like neuroimaging and psychophysiology, randomize them to the active or the sham, and again do neuroimaging and psychophysiology. For neuroimaging, we'll do the 2 tasks that I described, as well as resting state and DTI. And then for psychophysiology, we again use the same startle paradigm. And in week 1, week 4, and 3 months, we also assess clinical outcomes, mostly focused on hyperarousal. So to understand why the DLPFC is interesting, we work with the hypothesis that indirectly targeting the amygdala by stimulating an area within the DLPFC that's most strongly functionally connected with the right amygdala will be the best approach. So we will, the way we will do that is we will use the pre-TMS resting state scan for functional connectivity analysis and extract the time course for the right amygdala ROI. So this is the right amygdala ROI, and this is what the time course looks like for subject 1 and subject 2. And then we'll use this and correlate this time course with the whole brain, but look at the right DLPFC ROI, and within that ROI, find the area that, find the peak, basically. So basically, finding the peak area within the DLPFC that most strongly is most strongly functionally connected with the right amygdala. And that will be used to target for a TMS session. And I cannot look at your faces to see if this makes sense, but I'll show you a little video how that works. So we're using the BrainSight TMS navigation system where we can precisely locate this area on the brain. So here you see a native space structural T1, and the functional connectivity map is we overlaid it here, and this is the hypothetical coil. So this is in the system, we overlaid it, and showed a little video. So now I'm basically like peeling off the layers of the brain, and you can see I will move the little coil so you can see why I picked that area. So the darker colors mean most like higher correlation, basically. So you see that this is the area here that has the strongest correlation with the amygdala. So then we co-register in individuals' head to their individual native space brain using this device, and so we can precisely target that area with this system. And that way we hope that we can enhance the response by being very precise about where in the brain we target. So to summarize, prior studies have used clinical outcomes and mechanisms were largely unknown, but here we We'll use neuroimaging and psychophysiological measures to get a better understanding. We'll use an accelerated protocol of 20 sessions in 2 weeks. While we'll do, well, there's still no clear rationale for the 1 Hertz DLPFC, we'll collect biomarkers. We can see the effect on the brain and use this individualized targeting using neuronavigation. Here's something. And then we'll use, where most studies have used treatment-resistant patients, we're working with mostly treatment-naive patients with no, who are not receiving any other treatments for PTSD, including medication. And hopefully this information will help provide some preliminary analysis for future studies on predictors for the treatment outcome of TMS. With that, I would like to thank you for your attention and thank a really large group of people who worked on the different components of this study. And in blue are my mentors of my KO1 who've helped me design that and help me work with it, try to get this study off the ground, basically. Thank you for your attention, and I have my email address here in case you have any questions or would like to talk about something at another time, and I think we may have some time for questions now. Thank you so much.
Okay, thank you, Sana. That was great. I was monitoring the questions during the talk. There weren't any in the chat, but if anyone has questions now, please unmute yourself and go ahead and ask your question. So while people are working up the courage to ask their questions, I had a question. You showed some really interesting lateralization effects throughout all of this. Sometimes it seems like the right amygdala was very commonly implicated in many of the effects that you showed, but then there was a couple of times where right and left seemed like they were hyperactive, and I was just wondering if you had any thoughts about what is the role of lateralization in these effects, and is the rest of the circuit also lateralized, you know, for the connected frontal regions and so on?
Yeah, that's a great question. So indeed, we see when people differentiate left versus right in their neuroimaging studies, because not everyone does. I mean, it's also, people sometimes do like bilateral regions. But if people do look at right versus left, for example, Jennifer Stevens' study showed that indeed the right amygdala was particularly related to PTSD symptoms, to hyperarousal. And I think the most, the 2 ablation studies of the 3 ablation patients had like right amygdala ablation, and really that really was specifically related to improvement. So we are trying to understand if it's really the right and why that would be the case. There's not, it is the non-dominant sites, but it's not clear why that would be the case, at least not that I know of.
Yeah, it's really interesting.
But that's a great observation, yeah. And again, especially I think the neurosurgery work will be very essential in figuring that out, hopefully. Sharing my screen.
There's a question here in the chat. Will using EEG measures be useful in identifying the stimulation frequency for TMS?
EEG measures? Yes, there are definitely research groups using EEG in. Sorry, to be sure, is it to like define the targeting, or is it where is the chat? Stimulation frequency. Yes, so there are definitely studies using the EEG to measure basically the response, the motor threshold response, and use that as a sort of like a guide if they have the right if the right strength for the motor threshold test to do the motor threshold testing, and instead of like looking for the thumb twitch, they will do like an EEG and see see if they get the response.
So can I follow up quickly? Sorry.
Yes,
I
yes.
wanted to figure out, so in depression, there are some studies that suggest there is like a frontal alpha asymmetry, and that's partly the reason they go for 10 hertz stimulation. And I was curious if there are any other findings in PTSD, and could that help in going for a 10 hertz or say 1 hertz stimulation?
That's an interesting question, and I don't know the answer. The depression field is way ahead of PTSD in that regard. I believe there is a study showing that 10 hertz indeed is effective for PTSD, but there's really just a handful of studies that have used TMS in PTSD. So I think it can be very helpful, but I'm not aware of anyone doing it. Does that answer your question, or do you have any other thoughts you can share about that?
No, I was curious because since you have these patients who undergo invasive monitoring in the epilepsy units, like you showed a couple of examples, right? So you'd be able to pick up the EFIS activity from the amygdala and hopefully maybe with an EEG electrode or some other target in the cortex where you're targeting. Could you find some kind of interactions there that can give a hint on what frequencies would be useful?
That is a very interesting thought. We have talked about that. There's mostly logistical issues trying to do TMS with patients who have the in-depth electrodes. But
Sorry,
that is.
I think I was just wondering if you can get just without TMS, but just get an idea of what the interaction there is. Yeah, what frequencies.
Okay. Okay.
I can address that if you want.
Yes, please do, because this is not. I think you will be. This is Dr. Willie talking, who is the neurosurgeon, so he can probably.
So we have two NARSEDs on the subject. The one is the one that Asana is the PI on, where we're looking prospectively at what happens when we ablate the amygdala. There's a second NARSED that I'm the PI on, and I've been collaborating also with UCLA, where we are recording from the amygdala during a fear acquisition and fear extinction paradigm. And two things we're interested in: what is the response to the amygdala local field potential during fear acquisition and safety learning? And the second is, can we use direct neuromodulation of the amygdala to alter those things? So we've collected some subjects because, as you can imagine, the patients with epilepsy and electrodes in their amygdala is quite common, but we're also interested in the specific question of patients with electrodes in their amygdala that have PTSD, which is a smaller subset of epilepsy patients. So, of course, we're interested in just what happens to the amygdala with fear learning, even in patients without PTSD, but we're very interested in what happens in the amygdala in patients with PTSD. So we're still collecting data on that. I'm not saying it's fully analyzed, but what we're speculating is that we're going to see changes in amygdala power related to theta activity and so forth during fear learning. But we're looking mostly in gamma and theta ranges, but our analysis of that data is very, very preliminary, so I don't want to get too far into it. We are interested in looking at that question.
But thank you.
Thanks for addressing that.
Do we have time for another question?
Yeah, we have time for one last question.
So it was an interesting talk. Thank you very much. I have a question about the last part. Basically, the TMS localization, you're doing an offline TMS, right? You're doing TMS and then do the scan, a fMRI scan. So is it possible that you stimulate the brain and then record functional images, find the spot that you want, and then do it again in another session, and you land on the completely different place that you found in the first session?
That is possible, I think. I mean, it's like this is as robust as, basically this is as reliable as resting state neuroimaging is reliable, so it directly depends on that. So we kind of hope that we get a good sense of the connectivity using this 10-minute functional connectivity scan, but that's possible. It's sort of the rationale for doing it this way is being as precise as we can and improving the method that is out there, because the method that they use now is they find the motor threshold and then either go like 5.5 centimeters forward basically, and use that as a DLPFC, which, as you can imagine, is way less precise. So we're trying to really address that by using this method. But it will be interesting if we can. Maybe I can look at it in another study where we have multiple resting state scans of one person and see how consistent it is, basically. Because I mean, it's probably going to change. The other thing is, though, even though we try to be very precise, TMS is not very precise to begin with. So if it's
Right.
if it's slightly shifted, that's okay. We're just trying to be somewhat precise.
Right. Thank you very much.
Yeah, thank you.
Okay, great. 12:15 is our official, and because of the class schedule for Georgia Tech, people have to go. But that was a really excellent talk. Thank you for telling us about your work, Sana. And again, if students, postdocs, anyone in the audience is interested in the work, please get in touch with her in email.
Yeah, thank you so much for having me. And
Yeah,
please send
thank
me
you.
email if you want to. Bye.